Welcome to episode 12 of the ARME Radio podcast, the show where we aim to offer accessible education to healthcare and fitness professionals alike and to bridge academic research to the clinical setting. In today's episode, we're joined by Dr. Richard McIlmoyle, a chiropractor and educator with a postgraduate certificate in pain management, who's based out of Victoria, British Columbia in Western Canada. Richard has many years' experience instructing a variety of healthcare professionals through his own courses in pain management, works as an advisor, and has helped build the chronic pain management course for chiropractors for Pain BC. I would definitely advise checking that one out, and is a member of the board for the Canadian Chiropractic Research Foundation. He also owns and practices at his own clinic, Achieve Health, out of Victoria. This chat was really enjoyable for us because we really resonated with Richard's story and his development as a practitioner, when he was seeking out the complexities behind pain, questioning some of the iffy musculoskeletal healthcare narratives, using the best available evidence, and most importantly, trying to put the patient first. This is a development that we've all been going through early in our clinical and academic careers, and ultimately what inspired the development of ARME. So this was really refreshing and nice to hear from someone who's gone through a similar path, development, and who has only the best aspirations and goals for making musculoskeletal healthcare a more informed, trusted, and comfortable place for patients. You may hear a couple of dog barks and birds chirping off the start. Don't be detracted by that. That's only in the first minute or so of the conversation, as Richard was outside in his beautiful front yard in BC trying to catch some rays as we had this discussion. If you're a practitioner looking for further continuing education materials, Richard's courses are a great place to start, with more courses currently in the works. He's a great social media follow, and you can find out more about him at www.drrichardmcilmoyle.com. We will be sure to leave resources in the show notes. For more information and resources, be sure to visit us at www.thearme.ca. Give our Instagram page a follow at thearme.ca. Give Richard some social media love, and without further ado, we hope you enjoy today's episode.
Okay.
Are we recording?
Elliot, I can kick you out, and I'm not afraid to do it.
So that scenery in behind him makes it so she can't really see what's going on.
He's blinded.
Yeah.
Birds chirping.
Yeah.
Alrighty. Okay, so today we are lucky and fortunate to be joined by Dr. Richard McIlmoyle. Richard, thank you so much for joining us today. Let's start off for the people who don't know who you are. Can you give us a little bit of the background story of who you are, how you became a chiropractor, and what you're up to now?
Okay. Let's see. Well, as you said, my name's Dr. Richard McIlmoyle. I graduated from Logan College of Chiropractic in 1999 after doing an undergraduate degree in biochemistry at McMaster University in Hamilton, Ontario. I grew up in Southern Ontario. After chiropractic college, moved back to Hamilton, worked there for a couple of years, and then moved out to the West Coast here on Vancouver Island in Victoria in 2002. Purchased a practice, and then we've expanded that practice now to be, I think we have 15 practitioners in the clinic, physiotherapists, another chiro, a bunch of massage therapists, an acupuncturist. Yeah, so a pretty big clinic. Try to be interdisciplinary rather than multidisciplinary, which is an interesting distinction. After moving out here and practicing for several years, having a couple of kids in 2010-ish, had an experience with my business partner's, he's a massage therapist, business partner's wife. She was 8.5 months pregnant and herniated a disc, L5. It's quite bad, like quite large. And he and I, my business partner and I think contributed to making her a chronic pain patient with our reaction that we had to that disc herniation. I think, looking back, I think we played a role in it because of where we were in the biomechanical model, how big that was. I feel a lot of guilt about that. Anyways, that started both of us down a pathway of looking at things differently. Then Craig Liebenson posted something on his website with Lorimer Mosley, a talk by Lorimer Mosley. I listened to that, and pieces started to fall into place that made a lot of sense. It explained that idea through the biopsychosocial model, explained a lot of the variance that you see within our profession, where you have people just hitting C1 and people get better. You have people like rubbing little drums and poking things, people getting better. People putting blocks underneath them, people get better. People manipulating, getting better. People just doing ART, people get it explained the wide variance on how people got better. So I went down the rabbit hole of trying to understand the science on pain. And in 2016, I think it was, I was asked to help build the Pain BC course for chiropractors with Dimitri Asimakopoulos.
Well said.
Yeah, I work on that one. Yeah. So he and I and Lindsay Wright, who's another chiropractor in Vancouver, with a few other education folks, helped build that course out. And then, yeah, I started teaching the neurophysiology and sort of the pre-course for Dimitri, where I just give baseline information. And I've been working with Pain BC ever since, advisory role for the education, help them with some of their free stuff that they do. Then started, at the same time, started teaching by myself and with my business partner. He and I both do some courses together where we teach different massage therapists, physiotherapists, chiropractors, and then I'm doing one on my own. And then started my website to try to do some online education as well. So that's my journey. Long and circuitous to this point. Oh, I guess adding in there, yeah, then 2018 was the CCRF stuff. So that's when I got asked to join the board for the Canadian Chiropractic Research Foundation. And then last year we launched the research committee. So finally enough funds in the bank there to start issuing RFPs for people to submit directly to the foundation to provide funding for research. That's been super exciting to do, to have a hand in being able to guide a little bit where research money is going within our profession.
Very nice. Very good story.
Yeah.
No, that's because I think a lot of us can probably relate to that. With what you were saying, like, was your clinical practice style, stuff like that, just beliefs, quite different in the early going, like in the 2000s, mid 2000s when you just bought your practice? So was it almost like a fluke that you came across this video of Lorimer Moseley talking, or was there already some reflection of that incident when you were thinking, maybe myself and, the massage therapist might have contributed to this patient developing some chronic pain traits or aspects? So like, was it a slow process to get you to that point, or was it almost just like a light switch that went off and then you started going down that path?
The realization that we had played a role came later. We had this experience. His wife is going through this journey of becoming a persistent pain patient, or starting to live her life with persistent pain. And it sort of made me question. I'm going to take a step back to answer the first part of your question. I came out of school, was heavily influenced by Craig Levinson. His book, Rehab of the Spine, had just come out around the time I was graduating, or while I was in school, sorry. The next edition came out a couple of years after I'd graduated. But that, like the work of Yonda and Lewitt, it was pretty influential on how I practiced. So very biomechanical. That's the direction I went, because in chiropractic at the time, it felt like a real distinct dichotomy of, vitalism. I'm going to fix all, manner of ills through adjustment of the spine and fixing the nervous system. And then the other end, I wanted to go hard away from that. And so I went hard away from that and went biomechanics, and, took courses in running biomechanics, did everything was biomechanics, because that seemed to be where there was the plausibility of solid research to try to explain what we saw. Because you could see things happening in the clinic, and it seemed like that was the place to go. Then I have to say, so 2007, my first son was born. 2010, my second son was born. During those years, in early years in practice, after buying the practice and trying to build a business when you don't have any business background, I was just kind of head down treating patients, but lots of other stuff was in the fore, like just trying to figure out life on how to run a practice and all of that. In 2010 is when the thing happened with my business partner's wife, had a baby in 2010. So don't really know what happened until about late 2011. Then I was like, oh yeah, okay. I'm getting some sleep now. I have a son who can move on his own. I felt a bit stuck. I felt like I hadn't learned anything. And I realized I just had my head down, just practicing, just doing almost the same thing over and over again. Like just the way I was treated. I was doing active release. And then I started looking around for something else. And that's when I stumbled across DNS, actually, dynamic neuromuscular stabilization. And to me, it made more sense to try to have an overarching idea of how things worked. And then you could apply different techniques within a framework, that idea, rather than trying to find techniques to plug in. That resonated with me. So I went down the road and did the whole DNS Sport 1 and 2, DNS A, B, I think C. Yeah, I had done them all. And then like the next level was going to Prague to hang out with what's his name? Pavel Kolash. Yeah. So did all of that. It was really interesting, kind of really unique stuff they were doing. And then in the midst of all of that, doing those courses, that's when, the trickling in of stuff with Mosley I started to be exposed to that. Reading through that stuff and layering that on top of what I had already done. It's like the story that they're talking about, like in DNS, because that's where I was in the moment of developmental reflexes. Yeah, those reflexes might be going on, but if you look at this from a different perspective and through a different lens, you can see that this is really weird ways to move. I think this is just, I'm coaxing this person to understand their body differently. And all I'm really doing is having another option on how to get them to move. And so I use it still. I use some of the DNS like moves and different things. I sometimes will sprinkle a little bit of the explanation in there because it sounds fancy depending on the patient. And sometimes you just have to use that, right? You have to use whatever you can to try to influence the patient in a positive way. And I don't think I'm lying to them. I'm using little bits of it, little kernels of it that might be partially true, but it's just how it's affecting them might be different. So yeah, so that's that. I mean, I don't know if I answered your question there. I was wandering around.
Yeah, you did. And that kind of leads to my next point, and then I'll let the other guys kind of chime in here. I don't want to steal all the questions, but where you're talking about how you still use some of those explanations, that's just kind of taking advantage of the various contextual factors that can play into a patient's good or bad outcome. And you've talked about this quite a bit, and I've seen some of your videos. One that really intrigued me was just the environment. So how you can maximize your clinical environment to make someone feel more welcome. But if you wouldn't mind just chatting about some of those different contextual factors that you try to take advantage to help someone feel more comfortable and just maximize some of those outcomes for treatment.
Yeah, absolutely. One of the kind of seminal moments in that idea of environmental change for me was in San Diego one year. I can't remember what year it was. I've been down for the San Diego Pain Summit. And it was Sandy Hilton, and she showed a picture of their clinic. And their clinic in Chicago is a big, wide open space, brick wall, beautiful, beautiful room. And they have a section of it set up like a little living room. So they've got a little throw rug there. They've got a leather couch, a couple of leather chairs, a little coffee table, lamp. It looks like you've taken the living room and plopped it in there. That's where they do their patient interviews. She was talking about, she juxtaposed that in her talk with, I think my recollection was there were some images of doctors' offices and that cold clinical sort of how many practitioners want to have their office as looking like the doctor's office. I find especially, at least when I was graduating as chiropractors, there was this ethos within the profession of, always trying to be part of the medical world. And so we emulated, a lot of practices tried to emulate what a doctor's office, what a traditional doctor's office would look like. And it was rather cold and clinical. And she just gave the perspective of, if you're treating patients with chronic pain and they've been through the ringer and been to office, oftentimes that clinical cold sort of ethos of the office can be off-putting and can trigger that response, that bit of a stress response is, I'm just going to the same thing again and again and again. And so that really started to resonate with me, in that it's not going to be negative for most patients to have something a little bit softer, a little bit more living room-like, but it's going to be a big benefit likely for the chronic pain patients, people who need better care than they're getting right now. And a lot of the changes that we've thought about making, either with how we interact with patients, the language that we use, how the office looks, all of those other contextual factors, is you can change it and it won't matter for 80% of your patients. But the 20%, I'm just randomly making up a number here, I don't know how many it is, but the portion of patients who it's going to help immensely. The other 80%, it's not going to make much of a difference, but it's not going to hurt them for sure. So changing those contextual factors, getting rid of all the spine models. I don't have the nasty spine models. I used to have like the degeneration sequence of vertebrae that were sitting there just to use as like a teaching tool. But those are tucked away now. So if anybody ever asks about those, I can pull it out and say, yeah, so this is what it looks like, and here's what's going on. So I can use it, but I don't have it on display. All of the pictures in my treatment room are, like, I think I've got a group of 7 picture. I've got a bunch of posters of the NOI group, explain pain posters. There's nothing medicalized in there. Like, I just washed all of that away. So there's the environmental context. We try to have soft, kind of comfy, cozy sort of environment. And then there's the contextual factors of me, just, which I've kind of come to really, really explore. If you look at good practitioners who are successful, oftentimes they inherently do one or the other. Either they really are good at being empathetic, seeing where the patient needs to be and being the right person for that patient, or they're the really good salesperson who just blows through and sells like crazy and is really good at, there's the interpersonal stuff that is the biggest driver, I think, of that. Like, and if you go into practice and you've been in practice long enough, you get good at it. You get good at reading people and seeing what they need. So there's that contextual factor as well.
This might be a nice little plug for you too, but your manual therapy course for RMTs.
Yeah.
How did you change that narrative or explain what you're doing when you actually do hands-on approaches, the traditional chiropractic type of approach? Because obviously your mindset with this has changed immensely. It's not so biomedical. I'm not shifting. I'm not changing alignment. But how do you actually explain to the patient why you're doing it, especially when they come in with that already preconceived narrative of, I want some hands-on treatment?
Yeah, great question. And I'm going to put a caveat on this, like, it depends, but I'm going to start with talking about different narratives. So if you have the patient that comes in who's seen chiropractors before, has had the narrative of, I need to have something put back in place, I will, again, that the practice of assessing the patient cognitively, where are they heavily invested in this, or are they lightly invested in it? Are they open for a change in concept, or are they not? So you play that game of assessing that through questioning and like motivational interviewing type of techniques where you can pull out information from them to see where they are. But if they are open to change, if they're not open to change, I don't force it. I will just then mirror with my language, not using the language that they're using. If they're saying this needs to be put back in place, I think this is out, I will reflect back to them. Yeah, it feels different here. Yeah, let's do something to change how this part of your body is moving, and not force the battle on this doesn't go out of place. So I'll play that game with them. But if they're open for change, what I would say to them is, we're providing some sort of stimulus to your system. We're jiggling stuff around to try to change your perception about how you can move your body. And if we can change the perception about how you can move your body, you're probably not going to hold them as firmly. And then sometimes I'll jump back to the well, we've known since we were in school, since I was in school back in the 90s, that things really don't go out of place. What they do is they're just not moving as well as they could. But a lot of us haven't changed our language. I'm falling into my story that I do. So a lot of us haven't changed our language. But we've kind of recently understood that if you have the idea that something is going out of place, you're probably going to tighten up to stop it from going further out of place. And that's not good for you. So if we just kind of change how we understand it and we express it like it's not moving well, when you feel that thing that you feel, you're going to wiggle around and try to move it a little bit better rather than bracing and have to come in to see me. So this can empower you to do the things that you can do to help yourself move better. And so I just kind of spin it around, not trying to throw the other chiro under the bus, because that never works well. To say, here's the narrative and we've kind of stuck to it, but there's new information that says we should change our narrative on it, even though that chiropractor probably knew that it wasn't, even though he may have thought it was going out of place. I'm not selling him out by saying he probably knew that, but just didn't realize that we should change our language because it's easier to continue to say, oh, that's out. So did that answer? That kind of partially answered.
Oh, that was awesome. Thank you.
Yeah.
No, I think that's the one of the challenging parts is just understanding how impactful language is. And also, like you said, meeting the person where they're at and understanding their expectations, because we know that patient expectation is a huge driver in these acute pain situations, right?
Yeah.
Like there's even, like, if you want to look at like chiropractic specific work, there's that paper by Andreas Eklund's group in 2019 that was like the most important aspect of the prediction of them getting better was the belief that they were going to get better and the belief in the treatment that was going to work for them, right?
Yeah.
So is that how you try to operate in your office? Like, for example, we had Dr. Oliver Thompson talk with us a few weeks ago, and his mindset was if someone came in and they were really set on manual therapy, he was there trying to meet them halfway and provide that manual therapy because they really wanted it. But if someone came in with no expectations, he would completely alter his plan to see what he thought would fit best for the person. Is that something that you say you would resonate with that as well?
Yeah, 100%. Most people come in to see me as a chiropractor. There is some underlying expectation that I will be touching them, that I will be doing something culturally within society. People think of chiropractors as people who touch people and crack them, right? There's that kind of baseline expectation. So when I'm talking to people, I'll kind of assess where they are on that. But I probably have a handful of patients each week that come in that I will not manipulate them. Like I will do things, I'll do loading with them. Like I'll get them to load their bodies in different ways. I'll usually be doing the load because I don't have a ton of weights or anything in the office. So I will be the resistance for them, but I'll put them into different positions. I'll do different loads with them. And that's all. I won't manipulate their spine. I won't manipulate a joint. I'll do that. And I've had a few patients where they just come in and the conversation is the treatment, like the discussion, the assessment, you make sure everything's fine. Once they know everything's fine, they could walk out the door. But then we go through the ritual of actually touching them and doing something like, I'll do a little bit of mobilization or something like that. And it's almost like we both understand that wasn't necessary, but it's just part of the ritual. So we still go through that. It's variable, and I haven't listened to that conversation yet because I haven't gotten to that podcast, but I want to listen to what he has to say because it seems like it resonates a lot with how I practice. Yeah. So meeting the patient where it is it's a common catchphrase that we hear a lot, and I think it's just an inherent way that we practice, right? To try to give them what they need, unless we're one of those domineering sort of rollover, I'm the knowledgeable one, I'm going to tell you what you need. But it's interesting working with massage therapists, as going back to Mike's question about the course that Eric and I teach with massage. That whole framework isn't, you come in and you get touched for an X period of time, right? Like that's how people view massage therapy. And a lot, like I taught at a massage college for 17 years. So I know most massage therapists in town here. And we have that conversation a lot, that I feel they're best situated to treat chronic pain patients, in that they have a large block of time most of the time with a patient. The patient puts themselves in a vulnerable position by getting undressed and getting on a table. And then the massage therapist has the opportunity to go to areas of the body where the patient is feeling uncomfortable or pain, and touch that part of the body in ways like with skin drag or different things, and explore, does this feel better if I do this? Does this feel better? I don't know if you guys have DNM, the dermoneuromodulation that Diane Jacobs kind of coined the term of and came up with. If you look into that, that's essentially what they do, is they look for ways to pull and drag skin. I'm simplifying it massively. But if you explore ways to make the patient or the person feel better, there's a whole bunch of layers there that are amazing, because then instead of coming in to get an elbow dug into you as a painful, like I'm doing something to you, it then becomes this interactive, hey, let's try to find a way you feel better. So it changes their concept to say, oh, there's something that I can feel better, and I don't have to come in to hurt in order to feel better. There's a whole bunch of psychological layers going on there that can be maximized. I would never want to do massage. It's not my cup of tea to spend that much time in a room with someone, touching them and rubbing them. But I think it's an opportunity. I think they have a better opportunity for that. Our opportunity, I think, is different, I guess. Yeah.
Agreed. So, we've had that conversation before, where we talk about how like massage is a great opportunity to just let someone relax and kind of chill out and stuff, right? And you brought up a point there about like digging the elbow in, and I've seen it before. Like, we're almost taught in school, and maybe you heard this too when you were there, that the concept of temporary worsening of symptoms is a common side effect. And we've been kind of having this conversation even with another one of our colleagues who's doing some research right now, and we were wondering what your thoughts on this. Is it possible that sometimes we apply some type of force or hands-on pressure and make things worse, and when the person finally regresses back to the mean, which might have been what they were feeling before, it somehow feels relatively better, and that might be some of the effects that we're having with some manual therapies? Is that too much of a stretch, or is that potentially what could be happening sometimes?
I have a phrase, I guess you'd say, is I never say never, but then I'm saying never, so that doesn't work, right? So I rarely say never. So I wouldn't discount that as a plausible mechanism, because pain as an experience is 100% an experience that you have, and you can modulate that in so many different ways. The research on a noxious stimulus being of benefit is all wrapped up in the research they do on animals, the descending nociceptive inhibitory control, or DNIC, that we now in humans call conditioned pain modulation. So that idea of a noxious stimulus triggering firing from rostroventral medulla and the periaqueductal gray to suppress all noxious stimulus coming in. That research wouldn't support the idea of doing something, things get worse the next day, and then the recovery gets better. So that research doesn't support that idea. But that's just that. Because commonly people will use that as a reference point for why they do a noxious stimulus. I tend to avoid treatments that cause pain, unless the patient has had experience with that, has had benefit with it, and is not at a risk of that being bad. For example, like I have a fellow who comes in to see me, was like an semi-pro rugby player in Australia and has moved to Canada, and he is cycles like big ride type stuff, does like the fondos and different things like that. And if he does a bunch of big rides, he'll get this pain next to his shoulder blade, kind of periscapular musculature. And if you just get in there and do some like really aggressive, like active release, a couple of cracks here and there. He's good. I see him maybe once a year, maybe twice. He's not a risk. Like, he comes in, gets that done. Oh yeah, that feels better for him. And then he goes and does his stuff. So he doesn't need, but maybe he does, that big noxious drive. Like, I've actually tried to figure this whole thing out to I've coined a new term called nocehedonic. That's what I use for the good pain that people talk about, because pain, we say, is an unpleasant sensory experience. So when you say it feels good, that's counter to that isn't pain, right? By definition, pain's unpleasant. So if you're saying it feels good but painful, I just think we don't have the language to describe a high intense stimulus that actually in that context feels good because it's not a threat.
Dave, you have the title for our podcast today, by the way.
Yeah. Nocehedonic.
I love that.
Yeah.
That is good. That is good. Yeah. And the reason I asked that is because, like, I've kind of come to that conclusion too, where I don't think it's probably useful to be just digging into people and making things hurt more, unless it's outside of the context of where that person does think that feels good. So you answered that question perfectly there. But yeah, I was wondering if in some of the cases, maybe that might be what's driving them to feel better 2-3 days down the line. Maybe not, but we probably shouldn't, like, we always say, first do no harm. I know that's a small risk factor and stuff like that. It's still harm for some people, right? So we probably want to try to avoid that. Yeah.
I'm always a little upset if a patient comes in and says, you know what, I was a little bit worse yesterday, but I'm better today. Like, oh, what did we, like, I try to think, what did we do that caused them to be a little bit worse? Because I want to avoid that step. I want to have it where they just feel better, right? Yeah. So I actually had somebody last week. It's not super common, but she saw me as her first visit and then saw the massage therapist right afterwards in our office. He can be a little heavy-handed sometimes. So yeah, he's pretty good, but yeah, he's the one who's most likely to be a little heavy-handed if he's going to be. But
I wanted to ask you, because I know we've all heard it too. Sorry. The idea of, it's not if you're going to crack someone's rib, it's when you are.
Yeah.
So just back on that note, like, is that actually a good excuse? You 3, nice, okay. But do you actually think that this is something that's going to happen, or are there ways to prevent this? Kind of like what Dave was saying about you not having to dig your elbow in someone, maybe just changing how we approach these things.
That's a really good question. I think about my most recent one. She was an elderly woman, probably in her 70s. I've seen her periodically off and on for years. Like, again, like once a year or once every 2 years kind of thing. She would come in, and she had always had great relief with just a little spinal manipulation of her mid-thoracic spine. And this didn't look different, didn't sound different, nothing different about it. Wasn't super aggressive, but felt it happen. Like, she's osteoporotic and her rib broke. And so went through the CPA, called them up. We did the whole process. The thing that bugged me, I probably shouldn't be talking about it, but so I said, that's what just happened, is your rib likely just broke. Here's what's going to happen. We kind of talked through it. She was okay. She left. She ended up seeing her family doctor. She had an appointment with her family doctor for something else. Told her family doctor. Her family doctor freaked her out. You're never going to be the same. You're never going to heal properly from this. Like, all of these, like, and then you should go back to that chiropractor and ask for your money back. There's that, all, like, this whole big thing. She came back in the following day and relayed the stories to me, and she was super concerned about it. And so I had to try to sit down with her and say, okay, well, here's what we know about it. Here's the normal course. Gave her money back. I'm not going to argue. Like, there's no benefit to me fighting her over that. It's just going to add more stress to her life. So, and I haven't seen her since. That was a couple of years ago. But to me, I was more angry about what the doctor said to her about the misinformation about how bad it's likely to be for her. That upset me, because I mean, I've treated lots of family doctors in the area, and most of them will tell me, we don't get a lot of education on musculoskeletal stuff. So they will defer to me for that. And those who have an appropriate amount of ego control are willing to say, you know, that's not my specialty. Like that, I don't know a lot about that because we didn't learn a lot about that. They have a lot of other stuff that they need to learn a lot about, like a lot of physiology. They need to be able to discern all sorts of stuff. They're way, I would say, way better clinicians than most of us are because of the experiences they get. I was listening to, I always forget his name. Fella that you guys,
Jim Eubanks?
Yeah, Jim Eubanks. Yeah, talking about how, you know, the rotations and getting to see so many different clinical presentations. They do. They get more for that. But from a musculoskeletal standpoint, we see it all day, every day. That's what we do. It's our bread and butter. We are generally better at diagnosing these things, and so it bugs me when somebody who's misinformed gives misinformation and causes a patient potentially to have a long-standing pain outcome. So,
right, and that misinformation is challenging because that is a problem amongst MSK, amongst general physicians sometimes. And again, Jim said it beautifully: is GPs have such a vast plate they need to be aware of that it's unrealistic for them to be experts at everything, because their job is to be a fantastic safety net. And so sometimes they don't have that, and that's realistic.
Mm-hmm.
But what I do find interesting is, like you said, is chiros and physios and osteopaths, and so MSK should be the bread and butter there for all of us in that regard. So, but even within that realm, we do see a lot of misinformation. So with your platform, you try to spread a lot of just, like, again, truths and good information and supported concepts. So with that, how have you found fighting misinformation, whether it be amongst practitioners or even with patients? How do you approach that? I know we talked about the patient side a little bit, but what's your view, since you do educate and you do work with lots of other practitioners, what's your view about fighting misinformation there?
What Ben is really asking is, why aren't you getting in more fights on the internet?
Oh, fights on the internet. That's all what it's all about, isn't it? My fights always end up offline. That's the problem. I went through a phase where I was challenging everything online, and it was just like shouting at windmills. It was no fun. But with practitioners, usually it's what I've found. Like I used to take the Greg Lehman approach of belittling and telling them how stupid they were. But as he's learned as well, that approach usually doesn't work well. So questioning is where I feel you can get. It's just like talking to a patient about where they are in the stages of change. Where are they? Where are the openings that you can start to create little thoughts going on within their own head? Because I'm not going to be able to change them without presenting them with information, but then also having them question their own thoughts and beliefs. So one of the ones I like to talk with chiropractors about, because there's such a wide range, as I kind of mentioned earlier, like the guys who just hit C1, that's all they do all day long. C1, C2, C5 is an extremity to them. People get better. Like I have patients come to me that say, do you do NUCA? Because they've had success with it before for their low back pain. So how do we explain that? So how do you as a practitioner explain that? If your conceptual model is purely biomechanical, I need to move L5 in order for something in L5 to feel better, or the mechanics there, or regional interdependence of your, I don't know, your valgus knee is now causing your left scapula to move weirdly. How do you reconcile a patient gets better? And let's just sit on that. Come up with an idea. Tell me why that patient. What if I gave you this framework that is the biopsychosocial model, and the psychosocial stuff matters a lot? Does that seem logical to you, that now explains why that patient over there with what sounds like a really wacky explanation got better? Like those are the questions that I'll usually ask to see if they can go, like, I have a plausible mechanism. Does that make sense to you? And then start to break down other stuff. And it's like, but what about starts happening. You say, well, that might be a factor, but there's also these other factors. Remember, that also plays a role, right? Like my girlfriend, was a pro triathlete, and she had a persistent low back problem for years that was fixed with a heel lift. She didn't believe the heel lift was going to work, but it's plausible that the amount of load she's putting through her body, changing her mechanics just a little bit by changing that angle, like she's putting, 35 hours a week of load into, it's possible that the biomechanical change that was created by just that little shift was enough to offload it a little bit to allow that biological piece to be unloaded, right? She didn't have a lot of psychosocial stuff with it. She was still training. She was still doing all sorts of stuff. Yeah. Anyways.
That's
me rambling.
That's always like a really interesting point, though, because you often hear people who live by one type of intervention that might not have a tremendous amount of mechanistic physiologic evidence. It really does seem more contextual, that think, oh, well, systems, or I'm not even going to name, but some other intervention seems absolutely ridiculous to them. But maybe not just as many people, but people do get better. Yeah. And I guess that's just kind of showing, I mean, I would never do those things or sell them as this is going to work for you and do this big story, but like it shows how much power all those contextual factors that you were talking about before really have, right?
Yeah. I think we need to maximize them. Like people, like there's an ego piece here that is, when you're talking to other practitioners, can be an issue, right? Like if you're someone who has bought into a framework and you've spent all the money, you've spent all the time, you've examined, it's a really complicated system, you've used a lot of your brain power to figure out how the system works and how to apply it to different contexts. Maybe you even teach it and you have a financial gain by still buying into that. Trying to break that down is huge because you've invested, who you are is now that system, right? So it's like I remember when I did the shift, and you go down to San Diego for the pain summit, and almost everybody there is either in the midst of that shift or has gone through the shift, and it's oh shit, nothing works. Like it's this, like it's this collapse of you as a practitioner to then be rebuilt and be like, holy crap, now everything's an option. This is amazing. This is great. This makes my life so much easier, rather than like, oh, I'm useless.
I just want to throw out there, we're all the phoenix in the ash stage. That's basically where we are.
Yeah, excellent. Rising up. That's fabulous. It's a great place to be on the other side. It's really disturbing when you're in the middle of it, especially after a practitioner. This is the hard one for people who've been in practice for a longer time. Then you realize all the patients that I don't know how you guys are on swearing on this podcast, but all the patients you fucked up, right? That you were in on this and you couldn't figure out why it wasn't working, but you just kept on trying different biomechanical things. And then you're like, holy crap, I may have made them feel super fragile, and they may be a chronic pain patient because of me. That's a hard pill to swallow. Yeah.
So that's a really good point that I wanted to ask about and get your perspective on, is we should be trying to avoid turning patients into chronic pain patients naturally. That kind of goes without saying, and yet sometimes we're doing it unconsciously. So when you had your business partner's wife who had the disc herniation, how do you feel, without going into specifics, obviously, because patient health information, everything, but how did that occur? And how have you changed what you do, what you say, and particularly my question is for diagnoses. How do you frame a diagnosis? How do you tell a patient what it is that's going on? Because sometimes those languages can be quite scary to the patient and have negative outcomes.
100%. The great thing about being in general practice, I say that just because I think about like Dimitri, and Dimitri deals with chronic pain patients all day, every day. Most of us don't. Right, most of us deal with, my favorite comment on these people is from Peter O'Sullivan, the worried well. So they don't have anything pathological with them. They're just worried about what's going on. So the great thing is most people are like that. So when I'm give them a diagnosis, it's, you're not moving as well as you should. You've got some reduced capacity to move your body. So we want to expand your ability to move this part of your body. It's just, it can do that, but right now you're kind of holding the bracing. You're not allowing it to do what it can do. So let's get you so you can do that. When you do have something like a herniated disc, those patients, when we go through and do all the testing, I use the testing, like orthopedic testing, as a show of what they can do as much as what their limitations are. And if I suspect it's a herniated disc, I go, okay, here's what's going on. I suspect that the disc in there has a sprain of the outer ligaments. So I start to use language right off the bat that it's not the herniated disc. It's like the ligament has been sprained, and people it's a much softer term for it. I'll describe to them what the research says about a herniated disc is that it's similar to a sprained ankle, is that you don't want to be straining that ligament over and over and over again. It's going to take a little bit of time to heal. Here's what we need to do, but it will get better. The odds are that they're going to recover. It's going to take about X number of weeks for them to get back to doing some things that they want to do, but we should be able to do some things to help offload their pain experience right now. And by understanding that it's going to get better, reducing the fear, that will help as well. So I basically try to look at what the research says about how they're going to get better, give them those signposts as to what the expectations can be to get better when they have a physical damage that needs to be diagnosed. And that can be amazingly helpful. My business partner, Eric, when he has whiplash, or people who have come in with an acceleration deceleration injury from a car accident, he usually gives them a date and says, you'll be feeling better by that time, which is like kind of 4 to 6 weeks from the time of the injury. And invariably, they're better by that time, right? If you signpost that thing and go, bam, that's when you're going to be feeling better, you can almost make them feel better. It's that expectation piece that can make use of.
So what's the actual secret manual therapy technique he's doing that? Like, how is he getting that date? Is it a certain like rubbing technique? Is it?
Absolutely. It's a crystal actually that he takes,
perfect,
hangs over top. And if it spins 8 times in the clockwise direction, he knows that's a 6-week recovery. If it spins 3 times the opposite, that's 4 weeks recovery.
Is that only for Aries?
I believe it's amethyst, I think. Is
yeah, or an aquamarine. Gotcha.
Yeah.
Yeah, all crystals aside there, I think that's I think we all love that approach, is moving away from that harsh diagnosis to a prognosis approach. And I know there's a big push in the current literature to do that, right? Mm-hmm. Especially with things like acute low back pain, which have great prognosis, especially if you're providing patients with good education, you're, trying to kind of squash some of the concern narratives they might have. We know outcomes just get better, right? Or, well, not always, but most likely.
Yeah.
I'm going to pull a mic here and do the harshest transition known to mankind. But we just wanted to, before we kind of wrap up here, just wanted to ask a little bit more about your work with the CCRF and some of those stuff you're doing towards kind of trying to figure out directing where we should be paying a little more attention to in terms of our research. So totally open-ended question, as much as you can or can't talk about. Where do you see kind of research headed in Canada in this field?
That is a wide open question.
With the crystals.
Yeah, with the crystals. Yeah, definitely. As the research chair, we ask for submissions. We're still figuring out the process because we're such a new committee within the CCRF. There's some great people on the committee with me, good background, good minds. Sean Thistle, Aaron Poole, Peter Shipka, and Kate Hood are the other ones on the committee with me. And we're in a position not necessarily to direct specifically what topics are being researched. We've talked about that as a possibility in the future. This is sort of a little window in. I don't know if I'm letting the cat out of the bag, but we've talked about different options about what we can and can't do as the research committee. We could put a request for proposal out if there is something within the profession that is under researched that we feel should be researched. Then we could potentially in the future say, look, we're going to do an RFP for research on X, Y, or Z. It could be, oh, there's not enough research on crystals on diagnosis. So then we would say, we're going to put out an RFP for that specifically. But for right now, what we're doing is doing RFPs that are very broad. We're going to do 2 a year that are the spring one we're doing as a large kind of open-ended, everybody submit stuff. And then the fall RFPs that we're going to do are, this year we're doing early career researcher. So smaller studies, early career research folks, to try to promote that segment of the research population. So we're looking to try to really bolster the newer researchers as well as support the researchers that have been around for a while. And then topic wise, it's just whatever's coming across our plate. We want to be nimble to try to support things like the one that we supported in the fall that we announced with Stephen Passmore at the U of
At Manitoba, don't worry, I got
Manitoba. You. Thank you. Out of Manitoba, where they're in the hospital doing triage, and that I think is going to be great for policy, for increasing the not the scopes, but the profile of chiropractors, and I think it'll be able to be extrapolated out across multiple jurisdictions, because if you see how well diagnosis can go, we can reduce the use of resources like imaging or referral to orthopedics, reduce the use of opioids potentially. All of the different possibilities that could come out of that are phenomenal. I'm really excited about that one. That was a slam dunk for us as a research committee to say yes to that. So, yeah.
Maybe we could edit this out or keep it off the record if you'd like, but or even just your personal opinion outside of any affiliations. Do you think that there's anywhere that maybe we could be doing a little bit more research in? What's maybe needed a little bit more?
I think that we treat people because they tend to come to us because they're in pain. I'm a pain geek. I like to see research in pain, how to do it better. I think it would be great. This isn't chiropractic research, but I think it'd be great to figure out research on how to create campaigns to educate the public, because I think that's next. I believe if you look at like the biopsychosocial model, the initial paper that was the not position paper where it was created, Engel, there's a hierarchy that he has within that paper where the patient is the center of it. And then you look on either side, you go down to the cellular level, and then you go up to the population level. If you look at the population level, I think that's where we need to change people's ideas about how fragile or robust they are. And I think that's it'd be great to look at research on how to do that better. But from a chiropractic standpoint, I have a hard time calling it chiropractic research.
Because is that not like I find a lot of people, especially in those research areas, are kind of almost siloing things. Knowledge translation to the public and just changing and squashing some of these poor narratives is extremely helpful with how we can approach as clinicians in the clinic. And I kind of hope that there's not that limitation out there where chiropractic just means do more studies on SMT. Right. I think that's phenomenal work. And even talking with Tasha Stanton, she was saying that's something that they're really trying to work on, getting some campaigns out there that the general public can really relate to a little bit better than our typical means of education. I think that's fantastic.
Mm-hmm. Mm-hmm. Yeah.
And I mean, I am also a self-proclaimed pain geek too. So maybe I'm biased with your thoughts there, but
yeah. Yeah, Tasha and Lorimer and those those people have heavily influenced me. Like Lorimer, Greg Lehman, Ronnie Lennox Thompson, Joletta Belton, Keith Muldrum. All of these people have had a huge impact on me. I just, as I'm saying this, one of the things I think we do need to explore is patient experience. How do they experience us as practitioners? How can we be better at that interaction? So there is a bit of research going on in those areas, on how that interaction, how we can do that better. There's a little bit of research on that, which I think should be expanded. And yes, I do agree that research would be chiropractic research, but it wouldn't be only to benefit. I have a problem with chiropractic research, because what the fuck does that mean? Like, I don't understand, because I know some people hear that as SMT research. Like, if you say chiropractic research, that's all they hear, right? Because that's we've put ourselves into a one-trick pony silo by saying somehow we're different than physio, or like I've had this argument. I hope this could be on or off the record. I don't know. I've had this discussion. The guy I brought my practice from also went to Logan, was from Ontario, had moved out here. I bought the practice from him. We had these conversations for the year that we were hanging out together about how we felt it's all one big thing. Physio, chiro, massage, even occupational therapy could be thrown in there. And it's just, if you could educate all of us, and then you would have, I prefer to do more of this. I prefer to do more of that. You could have a more integrated approach to healthcare. And yeah, I think it would be better for the patient if we could do that and get rid of those freaking silos that we have, and political wrangling between each other, and yeah, the beating of the chest. I'm a chiropractor, I'm a physiotherapist. We're all just trying to help people get better. Like, let's just
we're doctors. Don't you forget that.
Fair enough. We earned that. We did go through school, but yeah, I think I can rant about that for a while.
Yeah, technically we have completed that, but
morally,
we put ourselves in by we, I mean the profession, even 100 years ago, put ourselves into this box, trying to double down on thinking that, manual therapy or manipulation is so important and special. And then it turns out it's nothing special. It's just another thing that helps some people. And as long as we keep pushing that divide, we need to think of the children, and this. It's not about the doctors. It's not about the professionals. It's only negatively affecting the people coming into the office. And sorry, I'm getting sad thinking about it.
So don't get sad. Don't get sad. Here's the thing. It can be super powerful. Like, spinal manipulation can be super powerful for a patient. That's why it's a hard narrative for people who've been doing it for a long time to let it go, I think, is because I've had the experience of treating a patient who's had like a long-standing painful thing. You treat them once, maybe twice, with some spinal manipulation, and they're miraculously way better. Like, it can have this tremendous effect on people, but there's the whole context around what happened in that interaction, and the physical thing that happened in their body. The pop was really fucking weird for them, right? And it created this sensation that made them all of a sudden, holy cow, that really did something powerful to me. Almost religious experience. All those layers go on. You can see how a practitioner could think it is the shit. It is the magical bullet, right? Like, I've seen that experience. I've had a patient, this is the craziest one ever. I had a patient walk in on crutches. I don't know what the hell he did to his foot, but he did something to his foot, came in, I pulled on it. It made a really loud pop. He got up and walked out without the crutches. Like, that's one of those, like, he was so freaked out by whatever was going on that he was so overprotective of it. We did something that made his whole system go, oh, it's better now. I don't have to protect it. He still had a bit of a limp when he walked out because something had happened to it, but it's just such a powerful experience for him that he had that. So don't be sad, Elliot. We will get there.
I'm miraculously cured of my sadness. Powerful explanation.
Yes.
I think that's a nice natural stopping point for this one.
Yeah.
We can end on some rare positivity on this podcast.
Yeah.
So a rare glimpse, a shimmer of hope. But so for everyone who's listening, can you please give your pitch now, your sales? Where can they find you on social media? Where can they find you on your website? Where can we get more Richard McIlmoyle content?
Okay, so my website is drrichardmcilmoyle.com. There's YouTube. I'm on YouTube, probably linked through my website. I'm just about ready to launch an online series of courses. I'm trying to set them up similar to what would be like if you're doing an online distance education. The course I did through the U of A for the pain management course, similar framework to that, with small videos, some readings to do that will hopefully help make people better clinicians. And where am I? I'm on Instagram at McIlmoyle Richard, and I don't know. I think Malleable Mind is my Twitter handle. Trying to remember all of my things. Yeah.
And your TikTok.
And my TikTok. Victoria Chiropractor is my TikTok. Yeah.
That was a great TikTok, by the way, with the cat camel.
Thank you.
There were some very natural like moments in there that I think just made it. But
yeah.
For those who haven't checked it out, go to Victoria Chiropractor on TikTok, or if you don't feel like going down that rabbit hole, go to his Instagram. He shared it. You can see just how flexible, mobile, healthy spine can be with some hip hop over top of that too. Just
it's a lot of fun. I have to say, TikTok is it's a fun thing to do during COVID lockdown, pandemic, isolation stuff. So yeah.
All right, you heard it here first, folks. The future of chiropractic is actually in 15-minute dancing clips. All right. Thank you so much, Richard, and thanks again for coming on.
All right. Thanks, guys.